let's get back on it. The road, we're back on the road of what? Pelvis. And then tomorrow we have a neural review, right? Reasonable? Very good. Very good. All right. So Rachel, we're there. All right, let's start with the easiest specimen. This is the hardest specimen. Let's go and just do a quick review on where we're at to get back our bearings. Okay? So let's get back our bearings here. All right. Okay, so let's just get our bearings. Okay? Now, just for interest's sake, what are we looking at here? And there is a lady, what's my friend's name in green again? In green, right here. What's her name again? Kristen? Kristen. Kristen? And your name? Chloe. All right, very good. So Chloe, right?
CHLOE.
Wow. And Kristen?
KRIST.
Boy, she's very vocal. Chloe, okay. So, Chloe, what are we looking at here? Of a female. Reasonable? Is it a young female or an old female?
Young.
You think it's a young female? Like how young? Alright, so we see, she said it's a female. Reasonable? Yeah, it's a female. Alright, so why is she saying it's a female, Jai? Why? Why is she saying it's a female? And Rachel knows all the female features. So there she sees me there for highlighting, right Rachel?
Yes, sir.
And they're highlighting good on the screen. Wow, very nice. Look at that. Beautiful. Right, so we see the sacrum here, but the sacrum here is a bit
It's very curved.
Yeah,
sir.
very curved.
Very
Eh?
typical.
It's curved. She needs to get a bit of a straightening out of her sacrum, isn't that so? That'd be too hard. Wow, it's really curved, but leave it alone. Then we see the what? The coccyx. Okay, the coccyx there. Okay, attached to that coccyx is what? Something called the anococcygeal ligament. All right, and sometimes, just for interest's sake, this bone can get damaged, and that's when that gets damaged. That's a very, very painful situation. A very what? Painful situation. Very, 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 very painful situation. If you have a pen. That can be a very painful. When I was a student, I had a friend who looked just like Rachel. Beside, reasonable. She did chemistry with me. Did what? Chem. And in the last day of chemistry, we had to hand over all of our lab equipment. And there was something called a clamp stand. A what? A clamp stand, which is a thing like this. It's a metal, big metal bowl. Reasonable? And boy, I don't know how it happened to her. Very sad. But in no going down and bending down to take the things out of her lab cupboard, she went right onto the what? Onto the clamp stand. Like that. Room. The area of the perineum. Was that a good or a bad story? Very bad. Right? Really bad. That was a bad accident. Shoom! And ended up just what? Fracturing her what? Her coccyx. Yeah, luckily just that. Luckily just that. Reasonable? Alright? So sometimes we can get somewhat serious damage to the what? To the what? To the perineum by a what? An object. Reasonable? Okay. So boy, just maybe last year I nearly died. It was a bad story. I could not believe it. But it was a dark night. Okay, a dark night. And Gardner went and did a good Samaritan deed. So there was a lady in great distress and great distress and great distress. So I went to help her. Reasonable? But then in leaving, I didn't want her. She could not even pay. It was a friend of the family, could not even pay her light bill. So she was in darkness. Anyway, she's gone now. She died. And she came out on little things and all of that. And I said, no, okay. So I came to carry something. So I wanted to pee. But I said, no, I didn't feel like going in and the house is black and all that. I said, you know what, where do men usually pee? By a lamppost. I was trying, but my bladder was just wanting to what? Explode. And I went way over by Constant Spring and I went over this bladder. I cannot what? Survive. Reasonable? So lo and behold, I went. It was dark. You can't go in a bright place. I look for a dark spot to spring a leak. Anyway, so Rachel, there it is beside a telephone pole. So here there's a weird, and then all I suddenly felt myself doing is just going zoom down into a hole. There like that. Oh, it was a worse feeling. I just, and it was maybe like a little piece of zinc or something, and I stepped down, and all I felt myself is just going like this, zoom, vertically down. And my foot caught on something, just like that, boom, like at the side, like that. Because I don't know what it was at the side, like a piece of a tree stump or something in this one, cylindrical hole. So my friend, if I were a heart patient, I would have died. Dark and suddenly night. Okay, so anyway, I managed, I'm talking about this height, so I managed now to just gradually get myself out of this hole. Anyway, so lo and behold, it was rough. You know what I mean, Rachel? Didn't even feel to pee again.
Terrible
I just got in my car and said, Michael, and what were you doing? A good Samaritan deed. And where did you end up? In the hole. All right, so anyway, I went back a couple of days later to when I had to go back again to her, and I decided to go, and it was in the evening to inspect this hole. So somebody had just put a piece of zinc, and Rachel, when I looked down in the hole, first of all, it was some big sewer thing going way down. Lord, when I looked down, and coming out of that thing was just this long metal pipe, like a metal steel coming right up. So if I would have gone down, that would have gone straight between my legs, up through the pelvis, into the water. I would have been skewered like a barbecue.
Yes, sir, like a kebab.
What do you think happened was, luckily it was this piece of what? Tree stump that was sort of coming out at the side. They cut this old tree, like an old tree root or something growing on the ground, and then that I came. So I had to thank the Lord. Thank the Lord, eh? But I nearly met my what? End. He's ever a hole, like a skewer right into them. Give it a. I'm in a class teaching. Sorry. Let us turn it. I'm sorry. All right. Very good. But that would have gone. Isn't that so, Christian? That would have gone right through. And Zika, what was frightening, when I looked, and what do you think the name of the road was? Lemon Road. Lemon is a good or a bad one? A bad luck thing, eh? Lemon. Terrible. All right. Anyway, that poor lady was a very sad story because she had an orphan son. I don't want to, because maybe you know somebody who lives on that road, so I won't tell you any more of the story. But just that it was a very sad story. Very sad. All right. So the perineum, reasonable. So this is a female. All right. Okay, there's a female that we see here. Reasonable. Very sad story with that lady. Okay. Was a daughter just abandoned her child and just left the child. And never the child didn't know the mother. It's a very sad story. All right. No. What age we say this is? What age do you think this is? Rachel, what do you think this is? You're a forensic little lady, right? How old do you think this person was when they died? Roughly.
10.
I would say they're a little bit older, sir. Like maybe I wouldn't say like a teenager, like maybe late 30s, 40s. Because there seems to be a bit of teenage, so it's like.
What do you think next
You see there's some still one. Closure to her, isn't that so?
Yes, sir.
Right, some bones have not fully what? sealed off.
I don't know. The
Right.
bones seem very thin though,
You're very
sir.
thin because a young girl. Reasonable? A young girl. Relax. Because it's not her exam. Reasonable? So she maybe like was a young girl, 17, 18 or something. Right? Because we can see that this part hasn't fully closed off. By 21, everything usually just tends to close off. Reasonable? So you see that along the issue of pubic rami, that ossification is not what yet? Fully complete. So it's a young girl. Reasonable? Just leave it alone.
Okay, sir.
And then the bones are very fragile. So you find that this is from India. So the bones of people from India are very fragile. Right? They're not robust bones at all. They're very delicate bones. Reasonable? Indians tend to have very delicate bones. Okay? So they're not sort of robust. Okay? And there we see that this is a female. Alright, now just suppose we mark this in the exam right here. Right? We mark this in the exam. Yes, we mark this in the exam. Right here. Right? So who is this right here? Right here. So who is that right here? Who is this right here? And this is it? Can you see it? Let's look at it on this one. On this one. Right here. See, it's more prominent here. Right here. So the man with the grey shirt looking in his phone. Very good. It doesn't matter, no problem. So what do you think that is right here? So if this was marked in the exam, what is the name of this point right here? Right in Zico? You see the finger in Zico? So in Zico, what's the name of that point? Nicola, what's the name of this point?
Help me, please.
No. What is the name of this point? So it's something you know, man. Because it's between this bone, which is a pubic bone, and this bone, which is the iliac bone. And it's an eminence. Iliopubic eminence. Reasonable? So it's between the iliac bone and it's between the pubic bone, and it's a prominence. So that is called the iliopubic eminence. Kristen, what goes on to the iliopubic eminence? And sort of allows all the pelvis to be tilted. So this pelvis is sometimes getting tilted. Psoas minor. Right? What attaches to the iliopubic eminence is the psoas minor. Reasonable? Right? Where does the quadratus lumborum insert? Where does the quadratus lumborum insert? Where does the quadratus lumborum? You can see it on the posterior abdominal wall. You can visualize it. Yes or no?
Yes.
Yeah. To the 12th rib. To the medial half of the inferior surface of the 12th rib. We're just relaxing. There is a structure called the medial arcuate ligament. What's the function of the medial arcuate ligament? What's the function of the medial arcuate ligament? We are reviewing. What's the function of the medial arcuate ligament? It is one of the origins of the diaphragm. It's on the posterior abdominal wall and it's formed by a thickening of which fascia? The psoas fascia. Going from where to where? Formed by a thickening of the psoas fascia going from where to where? Just relaxing. We're just relaxing. Right, so this is T12. Reasonable. This is L1, L2, L3, L4, L5. And these are the what? The transverse processes. Okay? Just relax. Alright? And remember that the psoas muscle, so this is the 12th rib here, coming out like that. Remember that the psoas is going to arise from the lower part of T12 all the way what? Going down. Isn't that so? To insert into the lesser trochanter. Isn't that so? And then now, coming up in the opposite direction right here, is the what? Quadratus lumborum. Reasonable? And the quadratus lumborum is going to gain attachment to what? To the tips of the what? Transverse processes of the lumbar vertebra. Reasonable? Then there is going to be a structure called the medial and lateral arcuate ligament. The medial arcuate ligament comes from where? Where does the medial arcuate ligament come from? In Zico. Well, first of all, we have to put in what? The crura, isn't that so? So we have the crura, the right cruciate diaphragm, which is arising from L1, L2, L3, reasonable. The left process arising from
L1,
L1, L2. So the crura, reasonable. Let's just put in the crura right here. Then from L2 to the tip of the transverse process of L1, that's the medial arcuate ligament. Reasonable. Formed by a thickening of which fascia? The psoas fascia. Right? And then now from the tip of the transverse process of L1 to the 12th rib, then we get another thing called the what? The lateral arcuate ligament. This lateral arcuate ligament. So they are the medial and the lateral arcuate ligaments. And then arising from all of this will be the what? The diaphragm. Right? And diaphragm comes into our story because it forms the what? The most important posterior relation of the kidney. Isn't that so? The most important posterior relation of the kidney is the what? Is the diaphragm. Reasonable, which is arising from the crura. There is a median arcuate ligament here, median. Then there is a medial, and then there is a lateral. Reasonable? All right? And the diaphragm is arising from all of this. Remember that on the left side, there may be a deficiency, and that's called the what? The vertebrocostal or lumbocostal triangular foot. Vertebrocostal, so on the left side, so on the left side, watch here, on the left side what happens? There may be a what? A big gap, a big deficiency right here. Right? A big gap, big deficiency right here. So all of this is missing. So that the kidney is just resting on lung and pleural. And this area is called what? And that is called the what? The foramen of, or triangle of, Bogdalek. CK. Reasonable? The foramen or the triangle of Bogdalek. So this is very important in the surgery of the kidney. Right, Garcia? To know that the posterior wall here is what? Deficient. So there is no posterior wall there. So the kidney is just resting on lung and pleural. Reasonable? That's called a triangle or the foramen of Bogdalek. And sometimes in babies that are born with it, this congenital deficiency, sometimes even like at 1 day old and all of that, they have no seen that something seriously wrong. And stomach, spleen, all these viscera are up in the chest. Reasonable? So they have to do what? To correct that deficiency in the diaphragm. Reasonable? So at Bustamante Hospital, you see a lot of these surgeries going on for Bogdalek. Reasonable? All right. So very important. So we're just looking at some things right here before we start. Reasonable? We'll get right into this specimen here now. Okay. Remember, this structure is very important. And this structure is known as what? What's that structure known as?
Ischial spine.
Ischial spine. Reasonable? Ischial spine. What structures run in relation to the ischial spine? The pudendal nerve and the internal pudendal vessels. Anything else in relation to that spine? Anything running close in relation to it?
Ureter.
The
Ureter.
Well, yeah, the ureter more anteriorly, right? The ureter runs towards it. Very good, 300 marks. The ureter, we said, crosses the sacroiliac joint, isn't that so? And then travels on the anterior border of the greater sciatic notch to the ischial spine. So 300 marks. The ureter is in relation to it. But also in relation to it is the what? The pudendal nerve, which is S234, reasonable. The internal pudendal vessels, all right? And one more thing, and Sika, what else runs in relation to it? They have some EMQ set. What else runs in relation to it? Near to it, right? What else runs near to it? And that's the nerve to obturator internus. Isn't that so? The nerve to obturator internus. Reasonable? So running close to this now is the pudendal nerve, the internal pudendal vessels, and the nerve to obturator internus, right? And we said that in the older days, sometimes they still do it in certain parts of the world, they want to give a what? A pudendal block. Reasonable? So then the person just palpates along the lateral wall of the vagina and feels the what? The ischial spine. And then the needle goes right through and then with the anesthetic all in that region. Reasonable? That's called a pudendal block. Reasonable? All right. Okay, now let us move on. So that's a good thing. And then attached. So the question is to Chloe, what's the name of a young lady to your right? Hmm? Hmm? Crystal, okay. Very good. So Crystal, very good. We don't mind. Look at that. Crystal, you go into the exam, what's attached to the ischiopubic rami?
Well,
And you see a list of structures.
depends.
And it's a female.
The issue cavanosus.
Female.
A female. She says the ischio-cavanosus muscle. Is she right or wrong? It's a female. Is she right or wrong that the ischio-cavanosus runs along here? Right or wrong? Good or bad? Very good.
Very good.
And that ischio-cavanosus is going to be surrounding what?
The crura.
The crura of the clitoris. She is crystal clear. Very good. Very good. So there we see the what? The crura of the clitoris surrounded by the ischio-cavanosus. What's the function of the ischio-cavanosus in the female? What is the function in the female? It's a big muscle. I'll show it to you soon. What's the muscle for the female? To maintain an erection. Yeah, you hear that? You hear, guys? You know about these things, yes or no? No, all right. All right. Basically, it is to keep the clitoris engorged with blood. Reasonable? It doesn't really get erect. Reasonable? No. That will be a problem. A serious problem. Okay? So therefore, it is to keep it engorged. Reasonable? Very good. What else is going to attach here? Along the everted edges of the ischiopubic rami. Some fascia. Which fascia? Colles fascia. Right? Colles fascia is going to gain an attachment along here and just to the what? To the posterior border of the urogenital diaphragm. Reasonable is going to get attached also to the posterior border urogenital diaphragm to seal off a space here. So it's going to seal off a space. And what is that space known as? Crystal? What's that space known as? So the Colles fascia, which is a continuation of which fascia? Scarpa's fascia. And Scarpa's fascia is the membranous layer of the superficial fascia. So that Scarpa's fascia is going to becomes Colles fascia, goes into the perineum to gain attachment to the everted edges of the ischiopubic rami. And then to the posterior border of the UG diaphragm to form a space. Right? And that space is called what? Superficial perineal pouch. Reasonable? So there's a superficial perineal pouch in the male, there's a superficial perineal pouch in the female. So Crystal, what are the content of the superficial perineal pouch in the female? All right, so let us look at it. Right, so the superficial, let us look at the superficial perineal pouch of the female. All right, so let's move this one here. Very good. All right, so just relaxing. We're just going with it. Reasonable? All right, so what specimen? Are we looking at a male or female here? Male or female? Male or female we're looking at? What are we looking at right here now? Male or female? This is a what? So, here. So what are we looking at? This is a female, isn't that so? This is a female right here. What's the problem?
Nothing, sir.
Okay, so that is the what? The female, isn't that so? Nothing wrong with that. Very reasonable. So we see here the labia what? Majora. Reasonable? So that's the labia majora. Right in here, this erectile tissue is the what? The labia minora. Reasonable? So there you're looking at, and the labia minora is going to come up like that. Reasonable? And split. The labia minora will split. Reasonable? Let me try it again. So the labia minora will split to form what? What will the labia minora? So what's the name of the space between the two labia majora? the two lips. And that's called the pudendal cleft, which is continuous with the cleft between the buttocks. What is that cleft known as? Natal cleft. Very good. So the natal cleft. Reasonable? And the natal cleft is going to become continuous with the what? The pudendal cleft in the female. Reasonable? And then now, when we open further now, it's going to become now continuous now with what? With this area here, which is called the what? The vestibule of the vagina. Right? And at the front of the vestibule of the vagina right here will lie the what? The glans clitoris. Reasonable? So the labia minora comes up and then splits into what? What will the labia minora split to form? Right? So most of the clitoris normally is what? Hidden. You don't see most of the clitoris, you know. But there it is right here. So you trace the clitoris. This is a suspensory what? Ligament of the clitoris right here. Right? And this is not a young female, this is a what? An old female, reasonable? Alright. So there you can see the what? The glans clitoris right here coming down. This is the body of the clitoris. Reasonable? And over here we see that, so this is tagged for the last exam. This is a suspensory ligament of the clitoris. Reasonable? You can see it clearly? You can see it clearly? That's a suspensory ligament. Reasonable? And then now, what am I holding on to here now? What is this? What is this? And see there, it's erectile tissue. Watch here when I squeeze, it's like a sponge. Look at that fluid coming out. See the fluid coming out? Yes or no?
Yes.
You can see that fluid? And you can see that this is all what? Erectile tissue. Reasonable? Alright? So the deep artery of the clitoris will enter into the what? The crura. Reasonable? Will enter into the crura. And then that crura now is covered by what? Muscle. And that muscle is known as the what? The issue cavernosus. So when the clitoris now fills with blood, then that muscle is just going to come down and contract. Reasonable? And what nerve is going to cause that muscle to contract?
The perineal.
What nerve is going to cause? Perineal branch of pudendal. Isn't that so? Perineal branch of the pudendal. And here we can see this. And what is this right here? See right here, what is all of this erectile tissue? All of this is erectile tissue. Reasonable? Okay, so what is all of this erectile tissue? So literally the labia minora can become erect. Reasonable? They just become, when the female becomes sexually excited, all of the labia becomes what? Turgid with blood. Reasonable? And the clitoris will become turgid too. Reasonable? So what is this here? What is that called? Alright? And this is the what? That is the bulb of the vestibule. Reasonable? The bulb of the vestibule. See it right here? That's the bulb of the vestibule. And the bulb of the vestibule has what? Just under, just below the bulb of the vestibule, what is this here? Right? And this is the what? The greater vestibular gland. Reasonable? Alright? So when the ONG person is examining the female, the ONG person just goes like that and just puts a finger right in here like that and just squeezes right there. Reasonable? And right here, this is where the what? The greater vestibular gland is. So in Bartholinitis, which is a common thing for females, right? Especially when they become sexually active, reasonable, that gland can become very what? Enlarged, right? Infected, reasonable? Because we'll see that the ducts are large, reasonable? All right, so there you can see now, just right in that region there, that is where we'll find the what? The vestibular or the greater vestibular gland. So there we see the bulb of the vestibule. Okay, who is this structure right here? Who do you think this structure is right here? Who do you think this structure is right along here? This area right here. Who is that area right here? So who is that area right there? Right here. And this is the very important perineal body. The what? The perineal body, which is a what? Wedge-shaped fibromuscular node. Reasonable? A wedge-shaped fibromuscular node lying directly anterior to the what? To the, there you can see the anal canal. Reasonable? Okay. So there we can see now the bulb of the vestibule. We're seeing the what? The crura. There you can see the what? Now, the bulb of the vestibule, when it reaches the penis, I mean not penis, sorry, the clitoris, it becomes nearly like a thread. Reasonable? it will become thread-like, and then now enlarges to form the what? The glans clitoris. So the labia minora is coming up, and then the labia minora splits. Reasonable? The labia minora will split. Alright? So if this is the glans of the clitoris here, just like that, then the labia minora will come up and split to form what? The prepuce of the clitoris. Reasonable? So the clitoris has a hood, a prepuce, and then now will form now underneath what? Like just under your tongue, called the frenulum of the clitoris. So and the male organ also has a frenulum too. Reasonable? Alright? So you have the frenulum of the clitoris and the prepuce. Reasonable? And then this is going to be coming up now and will be continuous with the what? With the area of the mons pubis. Reasonable? So this is all a part of the female what? External genitalia. Right? Jai, what's the name of the female external genitalia again? No one else. No man, the family name for all of the female parts. What's the family name for all the female parts? And that is the what, Jai? The vulva. Alright. Very good, very good. Alright. That is the what? The what? Give a chance. Reasonable? Joey, you have to give a chance. Reasonable? So that the whole area there is known as the what? The vulva. That's the full female external genitalia. Alright? So there you can see the what? The large what? Suspensory ligament of the clitoris. Reasonable? And then if we look now, right here, what do we see? We see right here, what was tagged here are the nerves and vessels of the clitoris. Reasonable? So you'll see there, these are some of the nerves right here. So this is the what? That's the dorsal nerve of the clitoris. Reasonable? And deep down in there, we'll also see the dorsal artery and the dorsal vein. Reasonable? So the dorsal vein of the clitoris. Reasonable? They have deep fascia, but I've never heard it described as what? Book. I've never heard it described as book. It's just described as a what? The deep fascia. Reasonable? And they also have tunica albuginea. Reasonable? So they also, it is just like the clitoris is just like a mini one. Male organ. Reasonable? The only thing that is not traversed by the urethra. Reasonable? It has nearly all the elements of here. Okay, so there we can see, and now if we come over on this side here, then you will see the depth to which this goes. So when you dissect down here, no, listen to me here. Okay, you see nerves. You look at this. Do you see the nerves? Just say yes or no. Do you see nerves? Chloe, you see them now? I don't know, Rachel, are you putting them there? I can't look at both ways. A lot of nerves. Look at that. Do you see nerves? Yes or no? Wait, there. Oh, yeah, man. Do you see nerves here? Yeah. Okay, so I dissected them off. So I myself, when I was dissecting, I said, what the dickens is this? Right, so in the female, when you dissect it, right, then the nerves that are coming down to the female external genitalia are like coming down like rain. Like what, Chloe? Rain. So what is that telling you? Highly innervated. Reasonable? So the female external genitalia is what? Very, very richly innervated. Reasonable? Right from the level of the what? The labia majora. Reasonable? Alright, so what are some of the nerves that are going to... All of these nerves, and then just here, so... And it is said also, not said, but it is known, I can't remember the exact number of nerve fibers, but for size, the female clitoris is far more highly innervated than the what? The male what? Glans penis. Reasonable? Alright? Much more innervated. Okay. So when we look down in here, look down in here now. So Rachel, you see down there? Can the camera go down in there? Right down. Can it go down where my forceps is going down? Yes or no? Okay, well look down there. So this is another exam specimen right here. And what you must appreciate, watch here, I'm going to go from here. So wait, I'm going from where the thing starts. Okay, look at that. So this is about this distance is the distance of the what? crus of the clitoris. Reasonable? So if we put it back here, you see it comes right along here. Reasonable? So the crus of the clitoris is very large, and you can see the size of it too. All right, so you're getting an appreciation. Now remember that a lot of you will go into general practice. Reasonable? And let me tell you, most of the patients are coming to the one of three things. Either they are diabetic, hypertensive, or there is a problem down here. Reasonable? So a lot of females, so when you have your general practice, you have to have no end of what? Speculums. Reasonable? You always thought of cleaning and this and that. So there are a lot of what? Problems in that area. Reasonable? So the ONG people, even the general doctors, have a lot to do there. So there you can see the what? The crura. And the crura now goes way down. That's the labia majora. Reasonable? And then coming up right here, there. Bogo. There. Give a chance, give a chance. Wait a while. There. So this structure right here, reasonable coming out. Can you see that structure coming out right here? That's the round ligament of the uterus. Right? It's coming out through the what? Through the superficial inguinal ring. See the inguinal canal here? You see the inguinal canal of the female? Right? So that's the superficial inguinal ring. That's the aponeurosis of the what? The external oblique. So that is the superficial. And coming out right here is what? The round ligament of the uterus. And that is going to insert and spread out into the what? The skin of the labia majora. Okay. So you'll notice that when many women get pregnant, right, many young women get pregnant, that they start to feel a lot of pain down in their area of the vulva. So down in the groin becomes painful. So as the uterus is expanding, it's putting tension on the what? On the round ligaments, isn't that so? And where are the round ligaments attached? To the skin down there. And the skin down there is very richly what? Innervated, right? So you're putting tension, but the whole uterus is now expanding up. So the round ligaments now are put on what? On stretch. Reasonable? All right. Jai, you're understanding a little more about the female apparatus? Yes. Yes, you're learning a little about it? All right. Very good. The female what? Apparatus. Dr. Thomas in the exam calls it the machinery. All right. Female what to it? Machinery. All right. Very good, very good. All right. So there we see. So Jai, in what's the round ligament? So in the exam, they set up an exam specimen like that. You can see the round ligament coming out. We said the round ligament is a homologue of what in the male? The round ligament is a homologue of what we said in the male. And we should all know this by heart. Gubernaculum testis. What about the suspensory ligament of the ovary? Yes or no? Just yes or no? No. Ovarian ligament, yes or no? Yeah. Remember, ovarian ligament will continue as a what? As a round ligament. Reasonable? Which is going to travel through the layers of the broad ligament. Isn't that so? To travel through the layers of the broad ligament. They love to put a pin in the lateral part of the fallopian tube and ask you what is its nerve supply. The lady in the little striped top. Very good. Very good. So you can imagine it, love? The what? Where's a female there? You can pass that to me. Very good. All right. So there. Yes. So there they have a specimen like this in the exam. Reasonable. But of the actual specimen, I'll show you shortly. And they see now the round. The what? The uterine tube. What's the innervation to the uterine tube? Parasympathetic at this end. Always in the exam, the penicillin. What is it? What's the nerve supply? Christian, what is it? Cranial nerve 10, the vagus. All right, so the vagus will supply the what? The lateral end. Can you imagine that, Rachel? The vagus, which is what? You think of a gut. Reasonable? But the vagus is really a what? Vagus means what? Wanderer. So he has wandered and found himself where? Along the lateral end of the what? Of the fallopian tube. Reasonable? What about the more medial part of the fallopian tube? What's the parasympathetic nerve supply to that? The more medial part. And that's via pelvic splanchnic nerves. Reasonable? Down in that region it will be by the what? The pelvic splanchnic nerves. Okay? Now, what's the important structure that occurs in the ovarian fossa? Crystal, what's the most important structure to occur in the ovarian fossa?
Is the obturator nerve.
The obturator nerve. Isn't that so? So we may get irritation of the obturator nerve. And what's the name of the sign again? Tausche-Bromberg. Reasonable? Pain is felt to the what? To the knee. Reasonable? Right? Pain is along the medial side to the knee. Not neuralgia parasitica. Read? Neuralgia parasitica is involving this nerve. And what is this nerve here?
Lateral cutaneous.
It's the lateral cutaneous nerve of the thigh. Reasonable? Alright. So the female perineum. Right? The female perineum. Alright? The female perineum, as we know, has an anal triangle and a urogenital triangle. Isn't that so? And the two are separated off by fascia. Okay? So there you can see some of the structures that lie in the female perineum. Okay? So we see the labia majora here. In that area you see the labia minora. And we see it splitting into form the frenulum and there we can see the what? The nerves and vessels. Reasonable? So in the male, the deep dorsal vein of the penis drains to where? In the male, the deep dorsal vein of the penis drains to where?
Plexus of Santorini.
No? Where?
Plexus of
Santorini.
Santorini.
The plexus of Santorini. The prostatico-vesical plexus. Isn't that so? Right? In the female, it will just go to the vesical plexus. Reasonable? Alright, just to the vesical plexus. And remember, this is the situation of the greater or the vestibular gland. Richard, remember those diagrams?
Oh, just
Very good.
back.
Oh, I'm sorry about that. Very good. Here is a little wet. So let me just sort of. No, it's alright. That's going to protect it with. Very good. Very good. So I want to thank Rachel. This is our last major session, isn't that so?
Yeah.
So I want to thank you. You say thank you, very, very kind of her.
Thank you.
Very good, very good, very good. So Rachel is finishing up her master's in forensics. That's why she needs to know about age. Leave it alone. Very good, very good. So we're looking here now at what? At the side wall of the pelvis, the lateral pelvic wall. Reasonable? All right, that's the lateral pelvic wall. Okay? Would you say this is a male or a female? Enzika, male or female? You see here? Enzika, male or female? What's that purple structure?
There's no purple.
Yeah, that's the first.
Oh, that's
The vas deferens. Isn't that so? The vas deferens. A male. Right? So, Crystal, where does the vas begin and where does the vas end?
Well, it begins at the tail of the epididymis, right?
Right?
It ends behind the ureter. It ends in the prostate gland, right?
Where does it end? Give a chance. Where does it end?
In the prostate gland.
Where does it end?
Oh yeah, at the ampulla, right? Beside the seminal vesicle, and it empties into the prostate.
Where is it ending?
Behind the bladder.
So it ends in a something called the, right behind the bladder, very good, in a structure called the ejaculatory duct. Reasonable? It's going to end in the ejaculatory duct. So remember what's the relation, what's the base of the male urinary bladder related to?
SUV.
SUV, 300 marks. So the base of the male urinary bladder is related to SUV. The anterior border of the male urinary bladder is related to what? The cave of Retzius. The bow of the boat like that, reasonable, is related to what? So those are the inferior lateral surfaces, isn't that so? And the inferior lateral surfaces are related to what in the male? And female, the same thing. The above is the obturator internus, and below is the levator ani. It's like the bow of a what? A boat. Reasonable? No, I had visitors, the last 2 weeks were very rough. I had some people from Dalhousie University, then my relatives arrived just for like 2 days. So I had to take them out a lot of places. And where do you think I ended up with them? At a place called Lime Key. Now while I'm out at Lime Key, Richard, I have on my red stripe t-shirt. I have a very nice red stripe t-shirt. Reasonable? The red one is very nice. What are they doing while I'm out at Lime Key? Making ads for Red Stripe. I can't believe it. Making ads for Red Stripe at Lime Key when it's open Saturday. Right? With 2 beautiful what? Young ladies. Dressed in XYZ. Alright? So they asked, would I come and pose with white and we call it the nice young ladies? Reasonable? Very good. Alright. Leave it alone. So there is a what? There is a what? There is a what? The side wall of the pelvis. Reasonable? So it's going to end in the ejaculatory duct. So the base of the urinary bladder is related to SUV and what else? The
rectum.
What else? The rectovesical fascia. Isn't that so? Related to the rectovesical fascia. So the rectum has on its anterior part the rectovesical fascia, and then on the posterior part of the rectum, what's there, Crystal? I know you know. Anteriorly is rectovesical fascia, posterior what? Waldeus fascia. She's hot. And look at those wires there. Waldeus fascia basically is to what? To suspend the rectum on the sacrum. Reasonable? So the rectum is still there. Now, the most important organ in the body is for the male, the prostate. Reasonable? The most important structure for the male is the prostate. So forgive me, I am having to say something about the prostate. We're carrying on some people? Very good. So just for 10 minutes, let's look at the prostate. Reasonable? For 10 minutes, here we go, you can move this for the while. For 10 minutes, let us look at the prostate. What's the shape of the prostate? What's the shape of the prostate? So the bladder, this is looking at a side view. Right. Just relax. The bladder is shaped like this, like a boat. Reasonable? And it has a what? A neck. And on that neck now will lie the what? Yes. So the prostate. What's the shape of the prostate? What is the shape of the prostate? What is the shape of the prostate? It is an inverted, truncated pyramid. Reasonable? We should have a better problem. Or let me use this one. Very good. Now, students, this is very, very important. Reasonable? All right. So, one of the most important things, believe it than anything else I've done, is the prostate. Reasonable? So the prostate lies, the base lies in relation to the neck of the what? The urinary bladder. And is separated partially by something called the prostatico-vesical groove. And what travels in that prostatico-vesical groove? The inferior vesical vessels. Reasonable? And very important is the inferior vesical artery. Reasonable? So the inferior vesical artery is a very important thing. And what's the main arterial supply to the prostate? The inferior vesical artery. So the inferior vesical artery is one of the chief sources of blood supply to the prostate. Prostate has how many blood supplies? Three. Reasonable has 3. And the main one is from the superior vesicle, and the superior vesicle is coming from the inferior vesicle, forgive me. And that inferior vesicle is coming from the anterior division of the internal eye. Reasonable? The anterior division. Now, let's go over the relations of the prostate. Superiorly related to the neck of the urinary bladder, separated by a groove called the prostaticovesical. What lies anteriorly? What lies anteriorly? Anteriorly is what? The cava retius. Reasonable? Remember that the prostate now has 2 coverings. It has a true histological capsule and it has the fascia. Reasonable? and that is called a false capsule. Reasonable? It has a true capsule and it has a what? False capsule. And where do you find the prostatic venous plexus? Between the true and the false. Reasonable? Is it on the posterior surface of the gland? Yes or no? Is the prostatic plexus on the posterior surface of the gland? No. So there's a little lady here named Kristen. Kristen, you are doing a DRE. Reasonable? Okay? And you are feeling the prostate. Tell me a little about what is happening. What do you expect to feel?
Sunken.
You did it?
Sunken.
You're a young man who did it. I remember doing it with you. I remember I held my hand like this. Reasonable?
If it feels like
Right, so put the finger right here. Very good. Right, so if it feels like that, then it's nice and spongy, then it is like a juvenile prostate. Reasonable? So it's in good order. It has the posterior median groove. Reasonable? Now it may be over like this, means it's hypertrophied, but still it may be what? A little spongy. Not bad, it's just a benign hypertrophy maybe. But then now it could be what? Hard, and we could actually feel some nodules. And as we go in, what are we going to take the finger and do? We're going to feel for the groove and what? Then just see that the rectal mucosa is what? Freely mobile on the prostate. Reasonable? What makes it, what lies between the, so remember there's no venous plexus on the posterior aspect. Reasonable? Alright, so there is the rectum right here. There's the rectum right here. Reasonable? And then anterior to the rectum is something called what? Prerectal fascia. Reasonable? There's prerectal fascia. And then there is retroprostatic fascia. Reasonable? And then in between the prerectal and retroprostatic fascia, there is some loose connective tissue. Reasonable? There's some loose connective tissue. And this, all of this is referred to, so the retroprostatic fascia and the prerectal fascia and the connective tissue in between, all of that is referred to as what, Kristen? What is all of that referred to as? Very, very important. The females don't have it. The males have it. So the males have a wall. The females don't have it. Right? And this is called a, right, the fascia of Denon Villiers. Reasonable? The fascia of Denon Villiers. What are the components of the fascias of Denon Villiers? Retroprostatic fascia and prerectal fascia. Now, what do you think, and then there is some loose connective tissue in between. What's the clinical significance of Denon Villiers fascia, you think, Kristen? What do you think the clinical significance of it is? What's the clinical significance? Crystal, what do you think is the clinical significance of Denon Villiers fascia? Is it important? Yes or no? Very important. How is it important?
During the digital rectal examination, it helps the rectum to move freely over the surface of the bladder.
Yeah, but how is it important more functionally? Because you're only going to have rectal examination once in a blue moon, right? Not something we're going to go for regularly, yes or no? Reasonable? All right. I've done one, I'm up to now, I can't go back again. Reasonable, how is it you're going to do that examination? Not that exam, what is the function? The more important function, it forms an important barrier for the spread of cancer, malignancy from rectal cancer into the prostate, and similarly prostatic cancer into the rectum. Reasonable? So that's the fascia of Denon Villiers. What is the name of the upward continuation of the fascia of Denon Villiers? The fascia of Denon Villiers is going to continue upwards as what structure? The fascia of Denon Villiers continues upwards as what fascia? You're just relaxing, you know. The fascia of Denon Villiers continues upwards as what? Continues upwards as rectovesical fascia. Reasonable? Continues upward as what? Rectovesical fascia. Let me ask Kristen another question. Kristen, can we feel the seminal vesicles normally, yes or no? When you go to do the examination, can you feel the seminal vesicles, yes or no?
Yes.
No. Right? What's the word, Rachel? No. Reasonable? Rachel, do you like that word? No. No. Right. at home. No. Reasonable? So therefore, so because let me see the size of it, the finger. Let me see. Lord have mercy. We have also a whole heap of problems to even reach it. Reasonable? So you have very what? Tiny little fingers. Reasonable? Alright? Okay? Alright. Okay, so therefore you're going to have to really stretch. Reasonable?
Okay.
Alright? Reasonable? Right? But then no, but you will be just about the what, right? Okay? Reasonable? Alright? Okay? So there you can just basically, now when you go to the hospital work, so you're going to have to do a whole heap of examinations. Reasonable? There may be some morning if you're there, then you have to do a whole set of people there on the ward, and you line them all and you do a whole heap of them. Reasonable? So a long one after the other, after the other, after the other. Reasonable? So the are reasonable? Alright. So it just becomes what? Just very routine. Reasonable? Very quick. Okay, so topographical relations of the prostate. Above the neck of the urinary bladder, anteriorly, cave of Retzius, and as one of my students would have said, who was sitting here last time, pubic symphysis. And then in that space now, deep dorsal vein of the penis. Reasonable? In that vein, the deep dorsal vein of the penis, which is passing between two ligaments. Crystal, what two ligaments does it need? Crystal, what's the two ligaments of the deep dorsal vein of the penis? Richard, blow it up big for me.
The arcuate ligament and the
Wow, she's hot, very good. And you should know, you know. Arcuate ligament, very good. And the what?
transverse.
And the transverse perineal ligament. She's hot. Reasonable? Travels between the arcuate ligament and the transverse perineal ligament and drains into this whole plexus here known as a what? Plexus of Santorini. What's the inferior lateral relations of the prostate?
Well, the UG diaphragm, right?
The inferior lateral relations of the prostate, and it's coming in all the exams, both theory and EMQ. What is it? What is the inferior lateral relations of the prostate? And that is can only be the levator ani. So the inferior lateral relations are purely the levator ani. Because what here now? This is the what? What here? Look here, look here, look here. This is the what? Arcus tendinous. That's the arcus tendinous. So above the arcus tendinous, this is what? Obturator internus. Below here is all what? Levator ani. Reasonable? Below that level it is all levator ani. So inferior lateral is related to levator ani. Reasonable? We say the prostate is a what shape? An inverted pyramid. Truncated pyramid. So it's like going to Egypt and seeing the pyramids what? Upside down. Good or bad side? Bad side. Reasonable? Good side. Reasonable? So the pyramids are turned now upside down. Reasonable? So therefore, the apex of the prostate is in relation to what? What's the apex of the prostate in relation to? The apex of the prostate is in relation to what? Enzika, the apex of the prostate, look at this diagram here. The apex of the prostate is in relation to what? Enzika, no. Offering you gold. And it's in the MCQs, all over the MCQs, all over the place. Right? The apex of the prostate, truncated apex, the tip, is in relation to what? No Enzika. Go ahead. Superior fascia of the UG diaphragm. Very good. Right here is a what? Superior fascia of the UG diaphragm. Isn't that so? And then now, watch here. The superior fascia of the UG diaphragm, the urethra, the neck of the urethra is going to form what? Prostatic urethra. Isn't that so? And then from prostatic urethra now it's going to pierce the superior fascia of the UG diaphragm to pass through the urogenital diaphragm. Reasonable? It's going to pass through the what? The urogenital diaphragm. To be surrounded by this muscle. What's the name of that muscle? And then it's going to pierce the inferior fascia of the UG diaphragm, and the inferior fascia of the UG diaphragm is known as what? The perineal membrane. So we can make it thicker. That's even a thicker thing. Reasonable? And then now it's going to continue as the what? Penile urethra. Right? So there'll be a bulb. Right? Reasonable? And then attached on around here is the what? The bulb of the what? The penis. Isn't that so? So it's going to enter the bulb of the penis. So the apex of the prostate is in relation to what? The superior fascia of the UG diaphragm. Then becomes something called the what? The very good. So see how the instrument is placed? Boom. So that goes like that. Reasonable? Alright? So remember when it's turned in, you don't want to get into the what? To the navicular fossa. So then once you get it in there, you go just down like that. And then you want to maybe stretch it out down like that. Right? To what? To what? To? Very good. Alright? Now I have a special instrument to show you. It's in my office upstairs. But it's specially made for when the patient has strictures of the urethra. Right? It's specially made for strictures of the urethra. So that when you go in there in the strictures of the urethra, you just wind it up like that, and it just opens out like that. To what? To what? To stretch the whole thing out. Reasonable? Alright, so some of you are going to become what? Urologists. Reasonable? That little young lady back there, I think she's going to be a urologist. When a man comes, she's going to have all these whole heap of big iron instruments. Sit down over there and wait. Take off your clothes, I'm coming. You're a serious lady. Reasonable? So there is the what? The prostatic urethra. Then the prostatic urethra becomes the membranous urethra. Reasonable? Passing through the urogenital diaphragm. And the urogenital diaphragm has three components. 1, 2, 3. The three components are the superior fascia of the UG diaphragm, the muscle, and the inferior fascia of the UG diaphragm, which is known as the perineal membrane. In the male, what will be the content of there? The main content is that it's a meat sandwich muscle. So it's going to have the sphincter urethrae, which is formed by what type of muscle? Skeletal muscle. Innervated by which nerve? Perineal branch of pudendal. Reasonable? So that's the nerve when you say you're taking a pee and you want to just quickly stop, then that's the nerve, that the muscle that is just going to stop it. Reasonable? Reasonable? Very good. And that's the perineal branch. Okay, what else do we find in the deep perineal pouch? The deep transverse perineal muscle, remember? There's a sphincter urethrae and the deep transverse perineal muscle. Then the glands. What are the name of the glands? The bulbourethral glands. Reasonable. What do we remember about? Those can become infected with what? All things like gonorrhea and all those kind of things. Reasonable. So I see in the clinic today they're doing some big study now on gonorrhea. Reasonable. So those things, and then these will go right through and drain into the what? Into the pierce the perineal membrane to drain into what? Urethra. Reasonable. All right. Now, very interesting if I can take a half a second to tell you this, that the best research paper I've ever produced, and that is what you call a seminal paper. What kind of paper? Seminal, because that information will feed into what? A lot of other research. And that is when Gardner with 2 other people discovered the first case of syphilis in Jamaica. And what was the date? 940 AD. What was the case? That's my best paper produced in 2. And you know how long that research took me? 10 years. 10 years to do that paper. Got it accepted. So when we got in one of the top scientific journals, called the Journal of Archaeological Sciences. Remember? So that's a top journal, and I had to get a European grant and this grant, and I had to link with Oxford University, University of Sheffield, and also another university in Portugal, right? And I could have brought you the skull and showed you, but anyway, in about 1965, they discovered a cave in Bull Savannah. Anybody knows where Bull Savannah is? Nobody knows where Bull Savannah is. So that is out going to Savlamar and those areas. And Bull Savannah. You don't know anything about burnt savannah and Bull Savannah? People never been on any expeditions. Never? But anyway, very interesting is that what? Is that in that cave they found a lot of what? Arawak remains, Taino remains, skulls, pottery, all sort of things. And my good friend gave it to another colleague, the skull, because the skull looks exactly like a cauliflower. You know, when you go to the supermarket and you buy a cauliflower, you know what cauliflower looks? Yes, so when you have tertiary syphilis, that's how your skull looks. So when skull becomes tertiary, the outer table of the skull is just like a cauliflower. Reasonable? Yeah? So we found this thing anyway, just to make a long story short, is that the first person was given it from 1965 to 1990. They promised to do some research and did how much research on it? Zero. Right. So the person who was my good friend who made the discovery, and I was doing some archaeology, this is my hobby, says, Michael, let me give it to you, and maybe you can research it. So anyway, when I went to the lady who had it Rachel, I had to spend the whole day nearly with her, trying to convince her to what? She was a doctor, very old, to give it to me, you know, that I'd like to research. I said, the man who owns it says I can have it. Anyway, just as I was about getting fed up and ready to leave, she said, okay, I'll give it to you. So we went into her bedroom and right up into the cupboard. Reasonably, she took this skull down. They have a very interesting life, you know. Reasonably, very interesting. So anyway, we got the skull, and then immediately I knew that was syphilis. Reasonably, because I could just see all the markings of syphilis on it. And then the thing is that there is an enigma. Did syphilis arise here, right? Or did the Spaniards, did the Europeans bring the syphilis to this part of the world? So anyway, I got in touch with radiology, teamed up with them, we did CAT scans on the skulls and all sort of radiology and all of that. Then we linked up with University of Oxford, and I had to get permission from the government of Jamaica to cut off a little bit of the skull because it's like a national treasure, reasonable. I can't send away those kind of things. You have to have all sort of permits and all that. So we sent it to Oxford University and they dated it, 948. And then it was a lot of money, but we got a grant. And Oxford University says, because Oxford University also wanted to publish it as a separate article, meaning they're what they call an archaeometry lab that just deals with what? Radiocarbon. So would I send more skull? I send them another piece of skull. Then would I send them another piece of skull? So Rachel, at the end of the day, I got fed up because I said, look man, if I continue sending you skull, what will happen to the skull? It will disappear. But each time I have to what? Saw off a piece of the skull, right? But anyway, in the end, no, about 6 radiocarbon datings were done. Because it was very important to what it was saying, right? So very diagnostic of syphilis is when they get lytic lesions. So not only the cauliflower, but you get lytic lesions on the outer table of the skull and the inner table. You know what I mean? Right. So it was the first. So it showed that what there. Then when Gardner did further reading, now I found that some of Columbus's people that came back, they described it, you know, the sores on the what? The penis, the doctor who was with them. But he said that the Taino people were able to treat it and were able to get over it. And what do you think they used? The bark of the lignum vitae tree. Right. So the bark of the lignum vitae tree, which is, you know, lignum vitae, but it's really Guaiacum officiale, right? They made a decoction of Guaiacum and it was able, and then interestingly on the skull, you can see where there are new lesions and there are old lesions. So you can see this person was undergoing a long course with syphilis, was being treated, then it was getting better, then it was what? Coming back. Getting better and then it was coming back. Well, let me tell you, up to the 80th, if you look in my office upstairs, Gardner likes to collect all sorts of bangaranga. And there was some old pharmaceutical things that were sold off in Jamaica, like from the late 1800s to early 1900s. And there was the bottle, tincture of Guaiacum officiale. I bought the whole set of bottles just to get that one bottle, tincture of Guaiacum officiale. So syphilis, it was used for syphilis. But when antibiotics came in, then no. But just last, then we get back, is that we did some immunostimulant experiments and we infected animals with gonorrhea and then treated it with the bark of the lignum vitae and it cured all of them. Yes, I did that with Michael, but I haven't published it yet. Right, very good. And we also did that thing called guinea hen weed. You ever heard about guinea hen weed?
Yeah, I've heard of it.
It was Michael Gardner that was involved with the discovery of guinea hen weed. you look about it. Very interesting. Let us get back to what? Anatomy. But it wasn't that exciting. Right, and then I went to the Royal College of Surgeons in London, in their museum, and there was the exact type of skull. So syphilis has this beautiful picture of a what? A skull that is like a cauliflower. It's very good. Rachel, that poster is up in my office, I think, you know, I can show them the skull, the picture, when I'm packing up. Would you like to see how the thing looks?
Yes.
All right, leave it alone. I will show you. All right. No, prostate. All right. So the prostate, now the inferior relation is the what? The superior fascia of the urogenital diaphragm. Okay. Posterior is what? The non-villous fascia and rectum. Reasonable? The non-villous fascia and rectum. Anterior is cave of Retzius, deep dorsal vein of penis, and pubic symphysis. Inferior laterally is the what? The levator ani. Superiorly is the neck of the urinary bladder. How many arterial blood supplies? 3. And the main one is via the inferior vesical artery, which sends off a lot of prostatic branches. Very good. Very good. So they send off a lot of prostatic branches. Very good. What's another source of blood supply? 3. The what? Very good, because in the pelvic, in the UG diaphragm is the what? The internal pudendal artery. So the internal pudendal artery also gives a blood supply to it. What's the third blood supply? Middle rectum. So the middle rectum, which hardly supplies the rectum, is a source of blood supply to it. Okay. Now, clinically, the most important thing about the prostate is the venous drainage of the prostate. So the little lady in purple. Very good. Because do you know her name? Okay. Very good. Do you know her name? But I don't believe this. Antoinette, very good. So very good. So what is that? So the venous drainage of the prostate. Reasonable, the venous drainage of the prostate is to, well, internal iliac veins, because the artery is primarily internal iliac, so to internal iliac veins. But most of the venous drainage from the Santorini's plexus, so from the plexus of who? Santorini, right? From the plexus of Santorini, where will it then go? This is called prostatico-vesical. From there, this will then go to what? Where does that then go to? Enzica, or literally, where does it then go to? From the prostatico-vesical plexus, where is it going to go? Remember, all of us males are, 80% of us are going to end up with cancer of the prostate. You know?
Whoa!
80% of us, right? So that's not a good story. 8 out of 10 people is going to there. So where is it then going to go to? Very important is in the pelvis there is this vast thing called the pelvic plexus of Venus. Reasonable? So when you get a car accident and you fracture it, boom, right into the pelvis, then when this tears apart, then that is very bad business. Reasonable? From the pelvic plexus of veins, do they have valves in these veins? Yes or no?
Yes.
Where's that junior urologist back there? Do they have valves in these veins? Yes or no? Yes, but they are non-functional. Reasonable? And from here now, they will now drain into, so these are the vertebral bodies that are here. Reasonable? Those are the vertebral bodies that are there. They are then going to drain into what? The external vertebral venous plexus. Where do they drain to? The external vertebral venous plexus. Reasonable? And so this is the external vertebral venous plexus. Then from the external vertebral venous plexus, they go through the bodies of the vertebra. They go through the what? The bodies of the vertebra via veins known as BC vertebral veins. And then now we'll drain to what? The internal vertebral venous plexus. And where is that internal vertebral venous plexus contained in? In the epidural space. In the what? In the epidural space. Reasonable? Very good. And then now it will go up now to, from here to what? Skull and brain. Reasonable? It will then drain to skull and brain. So the prostate, many times they will get metastasis right up to what? Skull and brain. Reasonable? And we said the external vertebral venous plexus, the basic vertebral veins, and the internal, those three elements form the what? It's called the valveless plexus of Batson. Whose plexus? Batson's plexus. Right. And Kristen, I told you Batson looks like who? The Colonel. Batson looks exactly like Colonel Sanders, and he comes right down from that part of America, that area called what? Kentucky. Reasonable, and you nice to see, and he wears the same type of bow tie like what? Two little black ribbons. Reasonable? Alright, so that is the valveless plexus of Batson. So I have a nice picture of Batson, and Batson is in his office, and he's standing up in his office, and he's standing up, and there's a shelf right behind Batson. And what do you think that shelf is lined with? Chicken. Skulls. Batson's Alright. So that's very important. So the most important thing in there is the what? The prostate. Alright. Now let me just no. Let me show you a very important specimen. This one. Alright, so this now is a what? So this is a female reproductive system. Reasonable? Very good. Very good. Right. So this is the female reproductive system. Reasonable? Very good. All right. No. Very good. Excellent. Very good. All right. So when we look at this specimen here, right, you can see the what? The urinary bladder. See that? Richard, let's go from the back. Very good. Yeah, that's another better way now. Zoom in more. Hard. Very good. All right, come down a little more. Right here. Okay? So here we can see the what? The female urethra. Reasonable? You visualize the what? The female urethra. Reasonable? Okay? That's the urinary bladder. This is the detrusor muscle. Right, and you can see right here we're putting the finger in a space, and that space is known as what? The space is known as what? So that's the female. You see how the bladder is all what? You see how the bladder is all contracted? Reasonably, you see it there, Crystal? You see how the bladder is all contracted? Right, so there you can see the inside the mucosa of the urinary bladder. Reasonable, it's all contracted at the time of death, right? So there's no urine there. So there you can see the detrusor muscle. Then this is the what? That is the uterovesical. Reasonable. So there, that is the uterovesical pouch. Reasonable, which is now going down to the level of the internal os. So this is the isthmus of the uterus. See the uterus right here? That's the uterus right here. See the fallopian tubes? You see the fallopian tubes right here? See the fallopian tubes? Reasonable. There, see the fallopian tube, how it curves around? Right, so that's the ovary right here. So therefore that is the what? That is the mesovarium. Right, and this part up here, right here, that is the mesosalpinx. Reasonable? So there we can see the mesosalpinx, and there you can see the mesovarium. Reasonable? Right at the hilum of the what? Of the ovary. Reasonable? That's the hilum of the ovary right here, where the germinal epithelium is going to become continuous. Did I show you this picture? Richard, did I show you the picture? Did I show you this picture? Hmm?
That would be you.
Right. So this is in a good phase here. Reasonable? Alright? Okay, so this is a female that never had any. She's nulliparous. Right? And in the nulliparous, especially the ovaries tend to be more onto the what? Into the